A very warm welcome to all of you. A very good morning. Welcome to Global Associations for Physiotherapy. This webinar is conducted by Women's Wing Maharashtra team. I would like to give a short introduction regarding the Maharashtra Women's Wing team. Dr. Pranoti, she is the president. Vice President is Dr. Dimple Shah. Dr. Priyanka Tole, she is the General Secretary. Dr. Trupti Rasal, she is the Secretary. Dr. Mugdha Srifat, she is the Joint Secretary. Dr. Prerna Garge, she is the Treasurer. Dr. Trupti Rasal, she is the Secretary as well as she is the today's speaker for the topic overview in the site of trapezius muscle. I would like to Dr. Trupti Rasal request please start the session.
Yeah,
Ma'am,
ma'am,
please
sure.
you can start the session.
Yeah, okay, sure. So, very good morning to everyone, and today we are going to discuss doing the overview on the trapezitis, like what is the trapezitis and what are the things including in this anatomy, physiology. I would like to let you everyone know that we are going to cover the physiotherapy point of view only. So, please do cooperative for that. Okay, so we are going to start the basically trapezitis. What is the trapezitis, what is the meaning of trapezitis, and what we can do for in the physiotherapy in the trapezitis, for the trapezitis. So common things physiotherapists must know in these things. Basically, what is the trapezius? So trapezius, what is the meaning of trapezitis, the common population affecting with the trapezitis, how can one get rid of trapezitis, frequent trapezitis, and the significant role of the physiotherapy for the trapezitis. So what is the trapezius? Trapezius is the muscle. It is the upper back muscle, and it is the most important muscle in the plays important role as a postural muscle. So it covers the upper back anteriorly like this and the posteriorly like this. Okay, so what is trapezitis? Trapezitis, it is a inflammation of the muscle of the trapezius. In layman term, it is called as a upper back pain or the neck pain. Whenever the patient comes to us, they will tell us like I have neck pain, I have shoulder pain, or like I have a upper back pain or discomfort in that thing in that areas. So you have to take this thing into the consideration. So basically, what is the anatomy, physiology, actions, and physiotherapy treatment? So we are going to see in this in detail. So the trapezius covers the upper back of the body, as I told you already. Okay, upper back muscle, and surrounding that there is a lot of muscles like rhomboids major, minor, teres major, minor, then anteriorly sternocleidomastoid, scaleni, and deltoid muscle. So there are so many muscles, and it is the one of the muscle which connecting vertebral column to the upper limb, vertebral column to the upper limb. So it is a bridge, between the upper limb and the this thing. It is a bridge between the vertebral column and the upper limb. Okay, so muscles are the other muscles are like I will show you the G.A.P.T. Okay, how it looks. So this is way, in this way. So vertebral column, that is axial body, is connecting to the upper extremities by the by the trapezius muscle. Okay, so other muscles are rhomboid, as I told you, levator scapulae, latissimus dorsi. Okay, then this is the, so we are now going to see the what is the origin of the muscle. So the external occipital protuberance, that is the external occipital protuberance, and C7 to C12, thoracic vertebra 12. Okay, so this is the origin of the muscle, and it is going to inserted on the other points. I will show you. So the insertion, so basically trapezius muscle divided into the three fibers: upper fiber, middle fiber, and the lower fiber. So these are the upper fiber, then these are the middle fiber and the lower fiber. So upper fibers are inserted on the posterior border of the lateral 1/3 of the clavicle. So we have seen in this image, see, posterior border of the lateral 1/3 of the clavicle, see, like this. Okay, yeah, then the middle fiber, upper crest of the spine of the scapula and the medial margin of the acromion process. See this, upper crest of the spine of the scapula and the acromion process, and the lower fibers, deltoid tubercle, medial end of the spine. So deltoid tubercle over here. So origin is here. C7 external occipital protuberance C7 to the thoracic vertebra 12. Okay, so this is origin and the insertion. Then what is the blood supply for the trapezius muscle? What is the blood supply? Then cervical transverse cervical artery is going to serves the blood supply to the serve the blood to the trapezius muscle. Then the nerve supply. So the nerve supply, there are both the actions like motor and the proprioception. The motor part is supplied by the spinal accessory nerve, and the proprioceptive part is the supplied by the branches of C3 C4, that is the suprascapular nerve. So suprascapular like a cervical brachial plexus. So C3 to C4 suprascapular nerve, and this is the spinal accessory nerve, which is the motor in function. Okay, then the action, here comes to the action. So there are, according to the fiber, there are different action of the trapezius. So the upper fiber, what is the action of the upper fiber? Upper fiber along with the levator scapulae, there is the action of the shrugging of the shoulder, that is like this. So you have to we are going to take your shoulders up. This function is done by the upper fiber. Then what is the middle fibers? Along with the rhomboids, there is a function of the retraction, that is putting your both the shoulder blades together. Okay, so that is the retraction of the scapula done by the middle fibers of the trapezius. Then the upper and the lower fiber of the trapezius both together along with the serratus anterior muscle does the function of the abduction beyond the 90 degree, that is this is the 90 degree, and beyond the 90 degree it is the overhead activity. So overhead activity is done by the upper and lower fiber of trapezius along with the serratus anterior muscle. Okay, so whenever patient comes to you, these all the muscle actions might be affected 100%. So the and other function is the stabilization of the scapula. So trapezius covering all the area of the upper back. So stabilization is most important work done by the trapezius, stabilization of the scapula. Okay, then what are the causes of the trapezitis? There are so many causes, like according to the profession, according to the injury, according to the situation, there are so many causes, but I am going to tell you some generalized things or in common things, common causes of the trapezitis: repetitive strain on the shoulder, heavy bag lifting, tightness in the trapezius muscle, repetitive head movements, incorrect postures at the neck, at workplace or at home also. Then high pillow, using the high pillow, so the trapezius muscle getting hampered. So the symptoms, what is the symptoms is the whatever the patient telling you, it is a symptom. For the students point of view, I am telling you, because there are first year students also joining the webinar, so I am telling you the symptoms are the things the patient is telling you their problem. That is, I have a swelling, I have a neck pain, I have a heaviness in my neck, I have a discomfort in the neck, I am unable to concentrate on my task, concentrate on my studies, on my work, I am unable to complete my task, I have some disturbed sleep because of the neck pain. So these kind of problems they will tell you, that these are the symptoms, or sometime it is a sudden onset of pain, out of nowhere patient getting the pain. So sudden onset of pain, that might be one of the cause. Then the signs, what is the sign? Basically signs are the whatever the patient's telling you the problem, you have to elicitate the problem and you have to look for the sign. The doctor can elicitate from the patient's symptoms, that is the sign. So first thing, we have to look for the sign of inflammation, because trapezitis is the inflammation of the trapezius muscle. So there are the signs of the inflammation present in the trapezitis. So the basic signs are rubor, tumor, calor, dolor and functional liosa. So these are the Roman words. Okay, so the the meaning of the word rubor means redness, tumor means swelling, calor means heat. There is a localized heat at increased temperature. If you touch the affected area, you will feel the increased temperature, and in the other side it will not be there. Okay, it is a normal. So that is the calor, heat. Then the dolor, pain is there, and functional liosa, loss of function. Whatever the action we have seen in earlier slides, that functions might be affected in the patients. Then the tenderness, what is the tender? There is a tender point present on the patient's affected side, so it will cause a lot of pain. Whenever you are pinpointing, like you are touching the point, then patient will winces. So there is a grading of the tenderness, so you can grade according to the patient tenderness grading, like grade 1 tenderness, grade 2, grade 3. So these are the tenderness grading, so you have to put it into the detail while you are taking the history. Then spasm, the spasm, it is a spasm like a swelling, so you have to check for the spasm if it is a present. Sometime it is present one side affected, or it is not there in the unaffected, or sometime it is both the side it is present. So after that, active range of motion is affected. Whenever patient tells you I am unable to do the my overhead activities, that is what it indicates. Active range of motion is affected, actively patient is unable to perform the task, that is the active range of motion affected. Then the strength of the muscle is less as compared to the normal side. So whenever you are taking the patient's history, or patient, you are touching to the patient, doing any special test, anything to the patient, you have to check for the normal side first, normal side of the patient first, then only the affected side, because of the pain the patient already irritated and discomfort. So you have to check for the normal side first. So this scan sensation you will feel on this side, you can take the concern of the patient also, and you will get the idea how the patient will react. So the strength of the muscle is less as compared to the normal, because you have to check the both the level, unaffected also, affected also. If you are taking affected also, unaffected, then you will get the idea. Normally the patient has this much of strength, grade 4, grade 5, and affected area if the patient has grade 3 strength, MMT. So what you have to do, you have to increase their strength to the grade 5, that is his or her normal strength. Okay, so according to the like that. Then the paresthesia is the abnormal sensation patient is feeling, like tingling, numbness, heaviness. Okay, and this might be feeling in the upper in the neck region, shoulder region, then the till the elbow, till the hands, or all entire extremity. So you have to look for that if it is a paresthesia is present, so you can get the idea if the nerve involvement is there or not. So you have to look for that. Then the tightness of the muscle is mostly on the affected side, because of the overuse the tightness will be there, but you have to check for the both sides. So tightness of the muscle mostly affected, more tightness will be there in the affected muscle. Then the giddiness, it is present in some patients, rarely, but it is present in some patients, because trapezius is along with the so many muscles, because so many muscles get spasm, have a spasm, then patient is unable to perform any kind of movement of the neck, and they will feel like a giddiness, fainting down. So you have to look for that, and you have to be very cautious while treating such kind of patients. That's why you have to look for this sign. Then next is clinical. So for the third year, final year, and the interns, I am telling you the clinical things, how you can take the case, and this is the general format. Every college is following their own protocol, but I am telling you in general. Okay, so first is the history taking. You have to take the history very thoroughly in detail. Okay, then the demographic data like name, age, gender, work thing, other things, residential status, in which floor, or how is the environmental area. Like then pain history. In pain history, what you have to cover: pain aggravating factor and pain relieving factor. It is most important thing while doing a patient counseling also, and doing the treatment also. Then the medical history. You have to ask the patient if there is any certain kind of medical condition, BP, sugar, then some kind of other medical history, like the stroke patients also having the trapezitis. So many things, and what is the treatment they are currently going on, so that you can modify your treatment. Then the surgical history. What is the surgical history? Like if the patient is underwent the spine surgery, they will have the trapezitis. So you have to check the consideration also, put into the mind, yeah, that surgery is done, so you have to be very careful while treating the patient. Then the environmental history and occupational history, like this, if the IT profession, school teachers, or like this official work doing patients. So you have to ask for the history, because sometimes they have to overhead activities like this, sometimes they have to do the extreme activities while neck flexion. So you have to modify their ergonomical things, and according to that they have to follow that. You have to look for that if they are following it, and then only their pain will get released. So you have to take a history regarding this. Then the outcome measures we are using visual analog scale. Visual analog scale is a 10 centimeter scale, in which 0 means no pain, 5 means in middle there is a moderate pain, and at the end it is a extreme pain or is severe pain. So you can ask the patient by giving on the paper the scale, and you just ask the patient mark the point whenever whatever the pain you feel. Okay. Then the verbal analog scale, some patient are not able to mark the pain on the paper. Okay, so you can ask verbally like 0 means no pain, 5 means moderate pain, and 10 means severe pain. You are not able to, it is uncomfortable, unbearable pain. So you can ask verbally also. Then the next is the neck disability index. Neck disability index, there is a daily living activities are there, so that you every criteria like grooming, cooking, recreational activities, driving, that kind of everything activity, every task is there in the neck disability index. So that you have to fill the scale, you have to take fill the scale by the patient, and then you have to calculate the score. According to the score you can grade your patient as there is a severe problem, there is a moderate problem, or there is a much not much serious problem, like that. Then the next is the McGill pain questionnaire. In this you will in this questionnaire patient will ask like what kind of pain is, like throbbing, tingling, numbness, heaviness. So you will get the idea if there is a neurological things or not, and if it is a neurological thing, then the treatment again going to the different ways. Then the range of motion, so while taking the range of motion you will go like a goniometry or taping method. That this taping is measuring tape cervical range of motion. We can use the taping method also. In this method, in the range of motion you have to take the both the ranges, like active also and the passive also, so that you will get the idea how much you have to do the treatment to the patient. Okay. Then tightness of the muscle and the strength of the muscle. If the muscles are tight, you have to stretch the muscle and make it normal. And the strength of the muscle, you have to check for the strength of the muscle. And if they are weak, rather than the unaffected side they are weak, then you have to strengthen the muscle. So you have to check the MMT also. And tightness also, there are grading, so you can grade according to the tightness present, and you have to monitor the tightness of the muscle. If it is a less like that, and you can grade accordingly. Then the special test for the differential diagnosis, look for the radiating pain upper limb tension test. So if the patient is telling you I have radiating pain, then what you will do, you will do the upper limb tension test, so that you will get the idea which nerve is hamper and which nerve is going to create the problem. So you can treat that specific nerve and get the read of the patient's symptoms. Okay. Then the cervical spondylosis. Cervical spondylolisthesis, shoulder impingement, rotator cuff injury, other muscles like rhomboids major, minor, teres major, minor. So many muscles surrounding the trapezius. So you have to check for the specific muscles also, because sometimes it is the your test will be false positive. So you have to cross check it again and again. So after that, sternocleidomastoid tightness, weakness, or strength. So you have to do all the special tests for this, and then come to the diagnosis. Okay. So differential diagnosis. Then the other investigation, if the patient is coming to you in the chronic phase, that is acute phase is like the within the 2 weeks patient is coming to you, and after that the subacute phase, and after the month it is a chronic phase. So in if the patient is coming to you, it is a chronic phase, so they already have the X-ray reports, MRI, CT scan, because they are getting irritated by the pain, and doctors some also ask them to do the other investigations. So you have to put your clinical diagnosis and the investigations together, and then do the final diagnosis, that this is the proper diagnosis. Then the role of physiotherapy. Now your role is there for the physiotherapist. First is counseling and the consultation. So first point is patient education. So you have to educate to the patient regarding their present medical condition, because so many patients are get scared and get lot of stress that my neck pain is not relieving, I am not able to do any task, what will be happen to me, or so many things, so many questions. So you have to make the patient educate that this is the normal things, sometimes it is happens, but don't make any fake promises that I will relieve your pain anyhow. So don't make any fake promise, just try to say them we will try to sort it out your pain. Okay. Then the safety precautions. What are the safety precautions? To release the pain by modifying the mechanical, environmental, occupational thing, that is ergonomical thing. As I told you, you have to modify the things, like if the patient is doing the overhead activities, then you can ask the patient use the high level of stool or chair, so that his neck will be in the normal position, so that he is not able to he is not have to do this again and again, the extended position of the neck. So his pain is getting released. So like that modification, if the housewife is there, the patient is housewife, so you can ask her with the sitting on the sitting with the chair, you can chop your cutting, like if she is doing in the kitchen table like this, so you can ask to sit and then you can chop and this everything like this, so you can minimize the load and get the rid of the symptoms. Then the most important, teach the patient what to not do, that is the thing. Ask patient, this is your aggravating factor. Patient is not able to aware, patient are not aware which thing is aggravating their pain, so you have to elicit that and you have to tell the patient, this is the thing which is aggravating your pain, so you don't have to do this, so you have to avoid it strictly and encourage them the correct thing. So you are not supposed to do this thing, so you have to tell them, you have to modify this way, so that your work is not getting affected and your pain will not be reversed. Okay. Then the management, yeah, this is the acute phase, when the patient is coming to you in the acute phase, so we can ask the rise therapy, like rest, ice, compression, elevation, use of anti-inflammatory gel like a diclofenac gel, hot water fermentation, medication, meditations, especially when the you are assessing the patient and you are not getting any physical impairment. So what you will say, according to the his talking and behavior, you will come to the know, come to the point that he is taking lot of stress. So meditation is important for such kind of patients, because the root cause of trapezitis is stress. Because of the stress, our muscles get tight and the patient getting the problem of trapezitis. So if the patient is coming in the chronic phase, then this kind of thing they already done, so you have to focus on the next thing. So what are the next thing for such kind of patient? Practical approach. So the practical approach, first is the pain relief. You have to do the pain relief, so you can use the electrotherapy like traction, IFT, ultrasound, steep, hydrocollateral pack. Okay. Then other skillful approaches like taping, dry needling, cupping therapy, manual therapy, trigger point release. Okay, so many things are there. So some patients, you have to check for these things. Some patients are very phobic for the electrotherapy treatment, so they are scared whenever we are saying traction or IFT, they are scared to the shock and everything like that. So you can ask them such kind of skillful approaches like trigger point release, cupping therapy, dry needling, taping, manual therapy. So you have to take a concern first, then only you can start the treatment. Before without any concern, you are not supposed to start any kind of treatment. After the pain relief, what you will do? Range of motion exercises. So the range of motion exercises, normal school PT exercises like upper neck, neck, then shoulder, then like shoulder and the shoulder girdle muscle, so basic exercises. Then the trapezius stretching, in the starting phase you can do the passive stretching, then you can ask the self teach the self stretching to the patient and they can do at home and workplaces. So the trapezius stretching for the upper fiber, middle fiber and lower fiber, because trapezius has a 3 type of fiber, so you have to cover entire muscle of the trapezius. Then the add work, occupational modification and the look for pains, the same like ergonomical things. You have to, it is the individualized protocol, because every patient requirement is different, workplace is different, home place is different, arrangement are different, so you have to individualize design these things and you have to look for the pain. As you are telling the patient you have to do this kind of changes, that kind of changes, then next day you have to ask if the pain is released, if the pain is aggravated. If aggravated, then again you have to check for the next protocol or next changes. You have to focus on the next changes, what you can do. Then the focus on the strengthening of the muscles like trapezius, shoulder girdle, whatever the muscles are weak you find in your assessment, you have to do the strengthening of that all the muscles, because then only the patient will not get recurrent trapezitis. Then the plan the progressive protocol for the strengthening according to the need of the patient, his or her profession, because every patient is going to come to us, like if it is athletics, if it is a sports person, if it is a marathon runner, if it is a patient willing to build up their body, so every kind of patient comes to us, or housewife, or the patient who is doing only the office work. So according to the need of the patient, you have to change your strengthening protocol. So need of the need and the requirement of the high strengthening, progressive strengthening, is more in the athletics and the marathon runner or the sports person, but but in the patient which is working in the normal setup, housewife, you are not supposed to do everything. So you have to do the follow the general protocol. Okay, so what is the strengthening? How can you start with the strengthening? So first is the manual resistance. You have to ask the patient gravity against movement, whatever the you are going to strengthen the muscle, and you have to put your hands, use your hands to apply over pressure on it, and you can do the resistance training like manual resistance training. Then you have to use the weight cuff. You can use weight cuff. So in starting we will use half kg, then 1 kg, then 1.5 kg, 2 kg, in with the gap, like for first week you will do the half kg, the next week 1 kg, then next week 1.5 kg. So according to the patient age, gender and requirement, you can change everything. So you can plan your patient specific protocol. Okay, and you can sometime you can use one weight cuff, also you can use two weight cuff for the bilateral strengthening. Okay, according to patient comfortable. Then the theraband is again the resistance theraband, like you can use choose the color coding, like whatever the available strength of the patient, then only you can start like yellow, green, red. According to that you have to change the theraband with the specific days or specific time color code. Okay, then dumbbells, these are the different forms of resistance. You can use anything like theraband, dumbbells, weight cuff, anything. Okay, but you have to more than the manual like manual resistance, you have to build bit of progressive for that. Then the dumbbells, you can use the dumbbells also. Then high intensity progressive exercises. So these kind of exercises, as I have told you, these kind of exercises we are doing only for the athletics who is interested in bodybuilding, marathon runner, or this kind of people. So frequency and intensity of this kind of exercises is progressive, changing with the time and the duration. There are certain protocols for that, so you have to follow that, and then you can do the high intensity progressive exercises for your patient, design the exercises for your patient with the time. Okay, so this is the today's overview for my side. So if you have any queries, any doubts, please put it on the comment section. We will try to find give you the all the answers for you. Okay, all the answers for all the questions. So we are done here with this today's webinar, and let me know us the feedback how the webinar was, and thank you so much for your presence. Thank you very much. So we are going to end here our session.